Hello, welcome, and thank you for attending the first session of the Independent Hospital Pricing Authority's live Q&A webinar series. I'm Joanne Fitzgerald. I'm Executive Director of Policy and Classifications at the Independent Hospital Pricing Authority, and I'm looking forward to introducing you to this digital series. This webinar is the first of many to be delivered over the next 12 months. With the Q&A format, we aim to provide an avenue for you to engage directly with us at Ipper, and it's an opportunity for you to ask the technical experts who are leading this work questions relating to your work within the public or private hospital setting. Today's webinar is going to focus on the consultation paper on the pricing framework for Australian public hospital services for 2022-23. With the public consultation currently open until the 9th of July, we're aiming to provide you with some resources that you might need in order to have your say on the key issues which are impacting your work. If you didn't have a chance to watch the pre-recorded session, then we are going to provide a quick overview at the start of this session, and the recording will be available on YouTube afterwards. This is an interactive session, it's Q&A obviously, so I do encourage you to submit questions to the panel and to the speakers via the Q&A panel on the app. And our moderator, Dr. Trent Yeend, will direct them to the speakers. I will introduce Dr. Yeend now. Dr. Yeend is a data scientist at the Independent Hospital Pricing Authority and is also an Honorary Senior Research Fellow at Macquarie University. Dr. Yeend has a PhD in mathematics and over 15 years experience in advanced data analytics, statistical modelling and policy advice in the public sector and academia. Trent's been with Ipper since its establishment in 2011, where his roles have included leading the technical development of Ipper's national pricing models and several of the classification systems that Ipper develops and maintains. His interests are focused around the use of data to interpret physical systems, solve problems and innovate. I really hope you enjoy the session and I will hand over to Trent.
Thanks, Joe, and good afternoon, everyone. We're here today to discuss the paper on the pricing framework for Australian public hospital services for 2022-23. We have a panel of senior team members from the Independent Hospital Pricing Authority who have a wealth of experience and knowledge across all aspects of Ipper's work program, including policy, classification systems, pricing methods, and data collections. I appreciate that we also have a wide range of audience members participating in today's discussion with a variety of interests in our topic of discussion. I encourage you to all to post questions for the panelists using the widget tool in the corner of your window, and I'll endeavour to present these questions to the panelists over the next hour. However, if you have any outstanding questions at the end, I'll provide the details at the end of the session how you may get in contact with Ipper. So let me now introduce our panel members. First of all, we've got Joe, who you just spoke with. Joanne Fitzgerald is the Executive Director of Policy and Classifications at Ipper. Prior to this role, she was the Director of ARDRG Development and was responsible for the developing and managing the Australian Refined Diagnosis-Related Groups classification system. Jo has more than 15 years experience as a health information manager working within health classifications in both the public and private health sectors. Joanne has worked as a clinical coder, manager of medical record departments, and at the New South Wales Ministry of Health. So our second panellist is Sharita Daylight. Sharita has worked at the Independent Hospital Pricing Authority since 2014. Sharita is currently the Director of Policy Development and is responsible for the management and implementation of a range of policies and frameworks related to activity-based funding in the Australian healthcare sector. Sharita has experience in contributing to Ipper's pricing and funding models and safety and quality reforms through the development of the annual pricing framework for Australian public hospital services, which underpins the National Efficient Price and the National Efficient Cost determinations each year. And our third panel member is Dr. Samuel Webster. Sam is the Director of Pricing at the Independent Hospital Pricing Authority, where he leads a team of mathematicians and statisticians to develop the pricing models which are used to determine Commonwealth contribution to for public hospital services, funding of public hospital services. Sam has been with Ipper since 2014. In his previous roles at Ipper, he led the led the delivery of the National Efficient Cost for Small Rural Hospitals in 2015 and the National Efficient Price for Activity-Based Funding in 2016 and 2017. Prior to Ipper, he was a Mathematics Research Fellow with the Institute for Mathematics and its Applications at the University of Wollongong. So thank you to our panel members. I might just jump right in, and to provide some context and overview for our discussion today, I might first pose a couple of questions for you, Joe. So firstly, what is the pricing framework and how does it relate to the National Efficient Price Determination for Public Hospital Services that Ipper delivers each year?
Sure. So the pricing framework is the major policy document that underpins the National Efficient Price and National Efficient Cost determinations. So it really sets the framework of which Ipper makes decisions and determinations around the upcoming price for the next financial year. So it includes the pricing guidelines, which provide the overarching policy framework that guide Ipper's decision making. It includes decisions on what classifications will be used for pricing, on data collection requirements for the upcoming year, and also areas around the pricing methodology, such as adjustments to the National Efficient Price, as well as work around pricing for safety and quality. So it really is the major policy document which guides those decisions that ultimately end up in the National Efficient Price and National Efficient Cost determinations.
All right, thanks. And so with regard to the consultation process that is the focus of today's discussion, how is the information that is received through submissions for this consultation reviewed by Ipper, and how do they inform the final pricing framework?
So the consultation paper itself puts forward a number of proposals, whether that's proposed refinements, introduction of new classifications, proposed adjustments to the NEP that Ipper is looking at, and those proposals are put forward in the consultation paper, and we seek as broad a feedback as possible from all sectors in the healthcare system. So we have that public consultation open for a period of 4 weeks, and we receive and review a number of written submissions in relation to that. So those written submissions, all of the issues, the themes, the responses, they're reviewed, they're grouped together through a thematic analysis, and basically inform a final position that Ipper puts forward in a draft pricing framework. So some of those proposals are things that we might be able to investigate for the upcoming National Efficient Price or National Efficient Cost determination. Some of them do indicate areas which need a longer term work plan. Maybe there's areas that have been identified but there's not data available, for example. But either way, even if something cannot be addressed immediately, it still goes on the list of things that we consider in future determinations. So those that feedback is, as I said, informs the draft pricing framework, which puts forward Ipper's proposed decisions on a number of pricing policy issues. That draft pricing framework then goes for consultation with health ministers before finalising a final pricing framework ahead of the determinations early in this year. It'll be early in 2022 for the determinations.
All right, thanks, Joe. So I have a set of preliminary questions that I might put to the panelists while we wait for questions to come through from the audience. These questions have been collated from inquiries to Ipper regarding our consultation processes, and this one in particular. So let me just, and I won't necessarily direct the questions to any individual panelist. I might just, whoever wants to jump in and answer the question, they feel free. So I might just start with, with the process, with the consultation process. So asking as a stakeholder, do I submit? Do I have to submit on behalf of my organisation or agency, or can I submit as an individual?
So I guess you can submit as an individual, but I think it's important to make it clear, who you are and what your area of expertise is. And so submitting on behalf of an organisation or agency, I think, does add a lot of weight to your submission as well. So if you've got further comments on that.
Yep. And again on the process, so once a submission is sent to Ipper, how does the stakeholder know if their feedback has been incorporated?
I can take this one. So all of our submissions will receive an immediate response from our Secretariat team. Your submissions will be forwarded to the relevant section within the Independent Hospital Pricing Authority, and we will contact you if we have any further questions or require any clarification. So again, really important that you include contact details and a contact for the most relevant person for us to get in contact with. We'll also endeavour to provide a response to those submissions, and we, as part of the draft pricing framework, we also include a consultation report which consolidates all of the feedback we've received from stakeholders, and your responses and your feedback will be also included in that report.
Okay, so we've got our first couple of questions come in. I might just ask the first of these. So the question around what evidence is there to support increased costs for genetic services? What sort of evidence is being sought? So this is a question in the actual consultation paper. And does this include detailed costs for associated genetic testing?
So I can take that question. I guess it sort of goes to the heart of what we look for in submissions in terms of providing an evidence base through which, if stakeholders view that services are not appropriately priced or that they're underpriced, in terms of we need data in which to assess that. So we've received a number of submissions over the years in relation to genetics and genetic services, and it's something that we have continued to look at. What we really would like from stakeholders is information on whether that's costs or whether that is data that, not necessarily data they can provide, but evidence that they can provide that Ipper would have access to in the national data sets, which would support the hypothesis that genetic services are not priced appropriately. So, it's fine to make the statement and have that hypothesis around pricing. What we really need to do is to be able to identify in the national data how we identify genetic services, how that's costed, and how we might be able to test that for ourselves in terms of what are the issues with the costing of genetic services.
And I think adding to that as well, so it kind of, we've touched on it a little bit in the webinar that Sharita and I did a couple of weeks ago, and I'm sure we'll get into it more today, but any submissions or proposals or hypotheses that are put forward through the consultation process, if it involves a change in the way we price something in particular or how we treat a particular service, the data that's provided or the evidence provided is really key. So one of the really main driving points behind what we do is that it is data driven. All our policy, all our pricing is driven by data that we have, and so it's really important to be able to identify genetic services, for example, in our data collections and be able to see what the cost is or the cost differential, so we can use that to inform any decisions that we make.
Okay, so we've got a question about private patient neutrality. So there's a bit of confusion by the actual person posting the question as to what the actual changes in the addendum are. So the question is there still going to be an adjustment that will reduce the NWAL for a private patient?
Yes, the private patient service and accommodation adjustments will remain as in the admitted pricing models for P22 and onwards. So these are to align with clauses of the National Health Reform Agreement around private patients or patients being elected to be treated privately in the public hospital system. The private patient neutrality clauses that were introduced with the addendum earlier this year, or for 20 to 25 addendum, are focused around the payment parity between public and private patients in the public hospital system. So while there's always been a requirement to account for other funding sources, which might go towards patient care in a hospital, this is really around making, just stronger wording around funding provided for private patients and public patients in the public hospital system. And the real difference here is accounting for the state health department's contribution to hospital funding as well, to really ensure that there is no incentives or disincentives to, push for private election status.
Okay, so I've got a question here about unqualified newborns. So are pathology tests conducted on unqualified newborns supposed to be captured in the delivery of the DRG price? Newborn blood spot screening involves testing of all babies in Australia, and the funding for this activity has never been clear. I'm trying to understand the most appropriate funding model for these tests, as there is significant pressure to include more tests in the testing panels. How do we find out more about the costing of this activity?
So where unqualified newborn cost and activity are submitted to us, as part of our processing of data that we collect, the unqualified newborn costs are matched to the mother's episode on admission, and so those costs are accounted for in the delivery episode. So typically, this comes back to costing and data collection, if activity data collection, and if the costing of those particular records is performed, accurately, then those costs will be captured as part of the delivery episode. As far as like individual costs for particular tests, etc., is not something we currently, we wouldn't price particular tests for an unqualified newborn, but the total cost of that care is included as part of the AEF models.
Yeah, so essentially, as you said, Sam, that all hospital costs end up in the National Hospital Cost Data Collection. So we're not costing people. We probably have to confirm with our costing experts, but it's possible there is variation between hospitals in how those costs are captured, but either way they are captured and they will be assigned either to the newborn record or to the mother's delivery record, and they will flow through to us and end up ultimately in the price, which, as Sam said, at the moment is the costs are assigned to the mother's delivery DRG, and so therefore the price of the delivery DRG reflects that. It's something we're going to reinvestigate to ensure that that is appropriately covered in this upcoming NEP.
Okay, so the costs associated with the healthy babies are bundled into the price of the mother. So the next question is, under the addendum, Ipper is required to facilitate the exploration and trial of new and innovative approaches to public hospital funding to improve efficiency and health outcomes. How will Ipper assess the impact of health outcomes?
Ooh, very, very good question. Certainly the innovative funding models is probably some of the most interesting work that is upcoming, and probably some of the most challenging work as well. It's going to be a joint effort, I guess, between Ipper and the states and territories as the system manages. I guess our role as a pricing agency is to ensure that the national pricing model is not a barrier to innovation, which is why we're investigating alternative models to just activity-based funding, noting that activity-based funding is actually very effective for a large range of episode types and patient cohorts. But that there are types of patients or types of care that may have better incentives under an alternative funding model, for example, a bundled price or a capitation model. So one of the, there's, I guess, a number of areas, a number of what we've called predictable success factors when we're looking at the work around alternative funding models, and one of which is around I'm going to say it's evaluation, but it really is about assessing outcomes and value in, and we could probably talk for a couple of hours on what is value and what patient outcomes are the ones that should be captured. But it's one of the parameters which is going to need to be in place for states and territories and system managers who are delivering these innovative models of care, which may potentially have an alternative funding model associated with it, about how outcomes, how quality of care is going to be captured and how it's going to be monitored and assessed. And we're also very keen to work with states and territories on that as well.
I'll just add that obviously Ipper is required to do this work under the addendum, and as part of that we're working quite closely with the Australian Commission on Safety and Quality in Healthcare around, again, assessing value and those kind of things, as well as part of that work.
Okay, so I've got a question here on COVID-19. So what is the impact, overall impact of COVID-19 on the National Efficient Price, and has Ipper done any empirical analysis on this?
Yeah, that's a good question. So we're currently finalising our cost data collection for the 2019-20 year, which includes the first 3 months from when the COVID pandemic was announced, as the last 3 months of that collection, so March to June 2020. And that's, as I said, we're finalising that collection now. We've got some very preliminary data, but I think have yet to do any kind of detailed assessment of that cost data to understand how it's affected the cost of care. So I guess that's from our side as far as, what we're seeing empirically in our data collection. We've got a lot of submissions and a lot of, evidence and discussions have happened through various consultation process that we're currently working with to try and incorporate into the development of the next NEP, and also any other advice that we issue.
No, I think as Sam said, we're in the early stages. We know it is probably one of the most critical areas to look at for the NEP, and we are working closely with states and territories, but at the moment we haven't got sort of empirical data at the moment, other than the data which all of you will be aware of is in terms of the reduction in activity, particularly with the reduction in elective surgery, the increase in delivery of care through virtual means, which is already, through telehealth, which in the non-admitted sector is already accounted for in the pricing model, and, hospital in the home and some of that virtual care, which is also already, can be accommodated for in the NEP. But we really don't have any empirical evidence at this stage to inform an adjustment, and that's going to be the piece of work this year.
Okay, I mean, just on another COVID-related question. So one change due to COVID-19 was that hospitals tried hard to stop people physically coming into a hospital, for example, pre-transport assessment with paramedics to discuss if the patient should be taken to a hospital. So has there been any discussion about it, or how, if this type of activity, type of activity could be reported?
I don't think that issue has been raised specifically. Certainly, there have been a lot of commentary around changes to service delivery and models of care. As I said, I don't think that one was raised specifically. I think it's the sort of thing that we have to consider the scope of the National Health Reform Agreement and public hospital services, and paramedics and ambulance services are outside that scope as far as I'm aware. So that particular example might not be one that we necessarily accommodate, but there were other financial arrangements around COVID in relation to public health and public health payments, and in addition to hospital payments under the financial arrangements that the Commonwealth and states and territories agreed to. So, we will be focused on public hospital pricing. That's our remit. That's what we have to be focused on. But there are other mechanisms for care which may be delivered outside the public hospital system.
Okay, so next question. Can you explain why the definition of other non-admitted services includes home and community-based chemotherapy services, particularly since hospital in the home services are considered admitted services, and the MBS includes HST services as admitted services too? It's a bit confusing, says the questioner.
So this is where it'd be really great to be interactive, like Q&A. It could be like we could ask a question and then could receive some clarification information. But one of the greatest challenges it has is determining what is a public hospital services based on the National Health Reform Agreement in ensuring that, obviously public hospitals are not just admitted patients. So those definitions have been around since probably 2011, 2012. But also, I would say, yes, hospital in the home is an admitted service, but there is such variation between states and territories in terms of admission policy that there are, I believe, some states and territories that have admitted hospital in the home and not admitted hospital in the home. So the reason we have these definitions, which are quite broad, is because what one state or territory has as a particular delivery model is not one that another state or territory has. So what one state might call hospital in the home for delivering chemotherapy, another might actually count that as a non-admitted service. So we do have to be cognizant of the variation of what's delivered as an admitted service or a non-admitted service and how it's reported in data at the local level.
Okay, so I've got a couple of questions on HACs. The first one, so is there a possible dichotomy in the on the one hand, the restriction in the coding of chronic conditions under ACS 0002 to determine the complexity of a DRG versus the need to use chronic conditions to determine the Charlson index for the determination of the HAC complexity?
Because it was HACs, I was going to throw that one to you, Sherita, and it sounds like a no question.
Go on, Sam, you can have a go.
Yeah, it's an interesting question. So I'm not super well versed in ACS 0002 and what the restrictions are, but it is there are some chronic conditions which do inform the risk grouping for the hospital-acquired complication model to adjust for the risk of the patient. So they're not using correct me if I'm wrong, they're not using like the U codes, which I think
they're the supplementary U codes where the chronic condition doesn't meet the criteria for assignment under ACS 0002.
Yeah.
They use, so the Charlson Index uses what we call the chapter codes.
Mm-hmm. Yes. Well, does that assume that answers the question? So
I suppose I'd say that the risk adjustment model for HACs, has been based on data and gets looked at each year in terms of how well it sort of predicts or adjusts for the risks of patients acquiring hospital-acquired complication. So as data comes through, new data gets input into the risk adjustment model, and if we do see changes, like if we do see, for example, a reduction in the explanatory power of the risk adjustment model, we can delve into that and investigate and see whether that is, because of less assignment of codes or the like. So these things do get reviewed every year based on the latest data. So there is that sort of refinement process which builds in changes that we might see in the coded data due to changes in coding standards or even new codes or retired codes and the like.
Yeah, that's actually a really good point. So it is the risk of all the models, but particularly the risk adjustment model, since safety and quality is a fairly recent addition to the NEP determination. So the HAC pricing was introduced in the 2018-19. These do get very thoroughly reviewed each year, both internally and independently as well. So all of that, those aspects are assessed.
Okay, so another HAC question. Is there any intention, this is quite a technical question, but is there any intention to change the HAC adjustment applied in relation to the HAC version 3.1 mental health cohort denominator criteria?
Short answer is yes. So we, as the Commission releases new versions of hospital-acquired complication specifications, it's something, we'll always assess internally. We'll always look to keep up to date with the latest release or specifications of any of the classifications we use. If there's more you want to say, Sherita?
No. As Sam said, we've put in the consultation paper that we propose to use version 3.1 of the HACs, which includes the mental health conditions and as Sam said, we'll review the model and make sure that they're all appropriately accounted for before implementing that for NEP 22.
So regarding the funding adjustment for HACs, is this truly an adjustment, e.g. a reduction, or can an increase in activity offset this so that funding stays the same? Oh, I've just lost the question. Sorry, it skipped out of my screen. Where is it?
You'd have to give an explanation of backcasting now.
Yeah, so this is...
Yeah. What? Sorry, let me just continue. In what time period is the adjustment actually recognised by the LHN?
It complicates the question even further. So the HAC adjustment is, so there's a risk-adjusted so when the National Health Funding Body calculates the Commonwealth contribution to funding and subsequent distribution to the local hospital networks, there is a specific clause in the National Health Reform Agreement which, to ensure that an underlying change in the model that we might make, that if like a change in the pricing model, isn't going to impact funding, like there's not going to be an increase or decrease in funding because of the methodological change. And so this is this whole concept of backcasting, and it holds true for the adjustment for hospital-acquired complications as well. So where there has been a number of complications that are reported or identified in the data, this does result in a nominal decrease in the total kind of funding associated with that activity. The Commonwealth contribution model, like the national funding model, is based on growth in activity between years. And so the really key thing with the HAC funding implications is what's the change in the number or the rate of HACs. And so if there's an increase in HACs, so there's more complications, that change between years is that there's extra complications, the more avoidable complications are happening, which will ultimately result in a decrease in funding per unit, whereas if that HAC rate improves, that is recognised as an increase. So I think it is possible to offset, by improving the HAC occurrences.
Okay, so this question's on new technology. So how does Ipper incorporate or set prices for new technology, including medical devices, and how is new technology incorporated or integrated into the DRG classification system?
Yep, I can take that one. So Ipper conducts an annual process for assessing new health technologies. That's quite a detailed process. We review submissions from the Health Technology Reference Group, submissions from states and territories, as well as reviewing the Medical Services Advisory Committee website and their current applications that they're assessing. So I guess the main or the initial step we take in that process is to assess whether the technologies that are proposed or provided in the submissions are appropriately accounted for in our classification system and or can be appropriately accounted for in the classification system. We seek advice from our clinical advisory committee on the devices or the applications and submissions that are put forward. We then seek feedback from states and territories on the uptake and use of these devices. I guess the support from the states and territories is quite crucial in this process for us to be able to determine whether a change is required to our classification system to account for the new technology. Throughout that process, then we refer back to our clinical advisory committee and up to our pricing authority for approval on consideration for inclusion in the classification model, classification system. I guess that the crucial thing is trying to determine whether there is, in fact, a difference in cost and that a change is required to our classification system. In fact, whether there's a new DRG required or the cost associated to a specific DRG already accounts for the cost in the new health technology. The new health technology process is something that we are continually refining. We know that this is it's a new innovative space that, and as we've talked about, our innovative funding models and whatnot, that is something that we're exploring further. We're looking at potentially updating our classification, our acute care classification system, to include a process for capturing devices and technologies earlier in the process. At the moment, we have a 3-year development cycle process for our acute care classification systems, and obviously we're well aware of the fact that for a stakeholder to provide a submission for a new health technology to be considered is quite a detailed and a lengthy process. So we're trying to come up with ways to kind of better account for inclusion or consideration of new health technologies in that format. So very much a watch this space. We're aware of the challenges with getting these included, but I guess my big thing would be make sure that we'll have the support of the states and territories in providing those submissions to us, because again, we want to see that these are being considered or used within the state and territories.
Yeah, if I can add to that too, there are processes built into our classification development work program to accommodate new technology as a sort of business as usual process when we do classification development. So for the acute care classification for interventions, which is the Australian Classification of Health Interventions, that's based on the Medicare benefit schedule. So as part of the regular development cycle for that interventions classification, MBS updates are incorporated. So if you have new health technology or if you have items or interventions which have come through and are MBS items, they'll be incorporated to the classification as part of business as usual as well. And similarly, like the pricing model and that being based on cost and activity data for a particular year, even if we don't get a new technology brought to our attention, if that's being delivered in public hospitals, then the costs of those are informing the price of that DRG. So if there is a type of graft or a particular hip implant which is being undertaken in public hospitals and has been rolled out, that will inform the price of that particular DRG that it goes to. I could also add, I won't keep it lengthy, it's already been a lengthy response, but one of the areas for one of the key reforms in the addendum to the National Health Reform Agreement is around health technology assessment and having a more nationally cohesive health technology assessment process. So that is something that the Commonwealth and states and territories are working on, refining that. And it also does incorporate a process around highly specialised therapies. So those high cost, low volume, highly specialised therapies, which we have a role in managing as well. So there are lots of avenues to ensure that new interventions in health technology is accommodated for in the national pricing model.
Okay, so research and implementation. So what consideration has Ipper given to research and implementation of best practice? And is there any funding in the National Efficient Price for research and implementation?
I can take that if you like. So I'll go based on what I understand your question to be. So in terms of research, so there are some types of service categories that are still block funded but not under the ABF model. So at the moment, teaching, training and research is still managed under block funding arrangements. So states and territories provide on an annual basis, or actually twice a year, they provide initial amounts and then provide more confirmed amounts later in the financial year when budgets have been undertaken. States and territories provide they're block funded amounts for teaching, training and research, and it's all lumped together into a single block funded amount. So that's, I guess, the research component, and obviously the Commonwealth pays for a portion of that block funded amount, but it's not treated under the ABF model. Research, which is, part of patient care, if patients are in hospital and they're in a clinical trial and they're, receiving tests or the like, then that will flow through into the cost data and that will come under the ABF model. So research, teaching, training and research is an area of development that we've been working on since Ipper's inception back in 2011 to try and move away from block funded and to get it onto an ABF footing. It's really, really challenging with research. We do have a classification that we've been developed that's not priced yet for teaching and training, but we haven't been able to determine a classification for research at this stage. So, a move to ABF for research or a change to a funding approach for research is not going to be an immediate piece of work. I hope that answers the question.
Okay, so a further question on genetic services. Is there an opportunity in the consultation to suggest a new 40 series, allied health and or clinical nurse specialist interventions for genetic counselling by registered genetic counsellors?
Definitely there is, and I would just recommend that there is supporting information or evidence in there about how this, about where that service might currently be captured in the non-admitted classification and how this differs as a service in its own right, and some evidence on to support like a materiality argument, whether that's on cost or volume of services, would really help when taking that proposal to our board.
Okay, so and another genetic testing services question. So, can you please clarify that in theory, hospitals should be incorporating the cost of genomic tests in the total cost of providing non-admitted services?
Well, without any further information, I would say yes, that if that's a non-admitted activity that is being reported by the hospital, then the hospital should be, as part of costing that activity, should be reporting the inputs into that particular service event. So if that's testing in there. The only caveat I would add, I guess, is just, I don't know the arrangements around MBS, for example, and, whether that's covered under other Commonwealth arrangements. So that's probably the only caveat I would add. Is this a public hospital service or is it funded by other Commonwealth funding programs? Because that may have an impact. But essentially, yes, if a hospital's delivering a service and hospital costing is essentially capturing the inputs to that particular service. So at high level, yes, it should be reported as part of the non-admitted cost data.
Okay, so back onto HACs. Now I've got a question that goes, HAC for unplanned return to theatre is particularly problematic, triggers many false positives because there is no unplanned return to theatre flag in the national data collection, so relies solely on codes in the HAC list. These false positives frustrate clinicians and impact on their trust and confidence in the data for used for safety and quality outcomes. Are there plans to review the inclusion of this HAC?
Yeah, so this is a tough one because I guess we're aware that that particular unplanned flag doesn't currently exist, at least in historical data collections. We are bound to the specifications which are released by the Australian Commission for Safety and Quality of Healthcare, and so there is allowances for this as part of the specification. So we stick to that definition pretty closely, and do kind of evaluate the cost differential, the risk profile of episodes that have a HAC identified. I'm not 100% sure, but I think is there plans to introduce coding around unplanned?
Not that I'm aware of, national data development, because there's that one and there's also the ICU
one.
Yeah, so there are a couple where it's relying on national data development, and that unfortunately is just a long process in terms of getting system changes and commitment from all states and territories to collect new data items can be quite a long process. I don't know if it's really true if you want to provide some, I guess, background on the HAC.
So the Australian Commission of Safety, Quality and Healthcare have a HACS clinical curation advisory group who meet on a I think quarterly basis. Hasn't been as frequent because of COVID lately. However, they meet and review all of the HAC conditions and the specifications and codes that sit under that. At the moment, I don't believe there is a plan to review that HAC in particular, but you know, as mentioned before, we work quite closely with the Commission, so I'm happy to provide that feedback back to them, and we can ensure that that is added to the agenda for that clinical group to review.
Okay, so another one on HACs and in the context of COVID-19. So if patient care has been delayed due to COVID, and this increases the likelihood of the patient that the patient will develop a complication during an admission, is the COVID-caused delay, for the hospital in parentheses, accounted for in the HAC penalty? So effectively, the risk profile of the population has changed, and is this accounted for in our in the funding or the pricing?
Yeah, so when we develop the HAC risk model, it's always based on the latest data we have available. One of the key parts of that evaluation is looking. So I guess there's a couple of parts to the HAC adjustment. One is understanding the cost differential between episodes with a complication and those without. And so this is analysed, by complication type and controls for things like, length of stay and patient complexity and a host of factors. And the other part is the risk adjustment model. And as you mentioned before, this is reevaluated each year with each determination we produce. So there is those risk profiles, are reevaluated, the model's adjusted to account for any change in that. And if that proves to be a significant risk factor when we have the data for it, that will be accounted for. And I believe there is scope under the, I can't remember exactly which agreement it was, but when just after the COVID pandemic hit, which is, does provide scope to kind of reevaluate the cost of services if there is a strong evidence base that something was, incorrectly priced or recognised retrospectively. And so all these aspects of the pricing model were reviewed as that data becomes available.
I think the challenge with that one will be identifying episodes which were delayed due to COVID. Obviously, if the patient has had COVID or has a history of COVID, we can identify that. But if they are just more complex because they've had delays, that might be captured in the risk adjustment model through, complexity factors, whether that's comorbidities or the Charlson or any of the other risk factors we have there. So it's potential, but it's going to be a challenge for us to identify reason for delay or that they were in fact delayed surgery due to COVID. So I think it's just to continue to look at the data and see what it says.
Yeah, and it really comes back to what we were speaking about at the start of the session as well, where there are requests to review certain aspects of the model or suggestions for improvement. It is really crucial that it is something we can identify in the national data collections, because that is gives a lot of weight to how we address those proposals.
Right, so this might sort of go address, you may have partly addressed this question in your previous response, but can you explain in brief maybe the penalty for hospital-acquired infections and how this has been determined?
So hospital-acquired infections, so I guess this is one of the HAC categories, so it's similar for all the different complications, and that there are unique models for each complication to try and recognise the different impacts that they have. But ultimately, I did yeah, Trent's right. I did touch on it before. So there are two key aspects to that, and one's to identify the difference in cost with episodes that have a hospital-acquired infection and those that don't, controlling for all other aspects of the particular case mix. So that step one is to identify that, yes, this is a complication and there is a significant additional cost as a result of that infection or that complication. And the second part is to then analyse the risk profile. So this is looking at the patient demographics and diagnoses and etc., all the aspects of the patient medical record that we have to understand which of those aspects most strongly correlates with having that particular complication or infection. And that goes on to inform the different HACCP risk categories. So a very high risk patient that has a very high likelihood of having a hospital-acquired complication will generally have a very low penalty. So the higher the risk, the smaller the penalty is, as it's considered less unavoidable in some sense.
Okay, so we've got another question about ACS 0002, and the question is, well, will there be a review of ACS 0002, or what is the review process for ACS 0002? Coming from the questioner who was saying they're a person who collects data at the primary source, primary care, where they find a lot of impediments in the coding of what is significant in a patient's episode of care. And at a hospital level, there are a range of different stakeholders and auditors, different users and private health funds and so forth. And it seems there's potentially no clear arbiter as to when there is a conflict between the need for capturing primary care data as part of a patient episode of care, which is part of the electronic medical record, and the tertiary uses for research, pricing and funding.
Right, so there's a lot wrapped up in there. So answer the first part of the question. So on the work program for 12th edition of ICD-10 actually illustrating coding standards is a task we're calling the simplification of ACS 0002. So it is about, obviously there were changes brought in for 11th edition, and we've got a lot of questions in relation to that. So we're aiming to simplify ACS 0002 to make it clearer and to promote consistency, but not to change the intent of those 11th edition changes. So yes, there's work on ACS 0002. No, it will not be a significant change from 11th edition. We're just clarifying and simplifying rather than making a sort of significant system change. I mean, I think you've raised a very good point, I guess, about the different need for users of the data. We make changes in relation to coding standards in relation to considering the multiple uses of the data. We don't just look at it from a funding lens. We look at it, what researchers are going to need, what epidemiologists are going to need, what's going to be needed for safety and quality. So we do keep in mind those multiple uses, but we also have to keep in mind the intent of the admitted patient data and the national data sets and data collections, and the fact that ICD-10 is a statistical classification and a statistical data collection of admitted patient care. So it is not meant to be a health status of the patient at a point in time. It's about what was significant to an admitted episode of care. That's the parameters of the data collection, and that's upon which we make the decisions around the coding standards. So as the participant has noted, there's obviously, there's EMRs and there's terminologies, and there's a huge range of data out there, not all of which needs to be or will be in a national admitted patient data collection. So, we are mindful of the multiple uses, but it's users of the data will also have to be mindful that there are multiple sources through which they can get that data. It doesn't need to necessarily be just through ICD-10 coded data.
All right, we're nearing the end. We now have a question on newborns. So the questioner says they've introduced a donor breast milk program for premature babies. Would the cost of this expensive milk be included in NWOW, or is this, or as this is new, do we need to be looking at an adjustment?
I don't think any of us could really answer that question straight away. I suspect that's a good one to put in the submission so that we can investigate that further without knowing about the source of the program or any more details. I think put that in the submission with as much information as possible, and it's something that we can look at.
Yeah, and I mean, in general, if those costs are captured in the data and submitted to Ipper, then they will be accounted for in the price. So that's a fairly general, short answer. But
yep. Okay, so a further question on new technology incorporated into. So before the final classification and funding decisions are made by Ipper, how can public hospitals fund new technology if they want to use it?
I'm not sure we can answer that question either. It's really a sort of a state and territory system managers type issue. We try to account for technology as soon as we can, as soon as we're notified. Obviously, we are working to make our classifications more responsive, but every change and update obviously has, burden to jurisdictions as well. Our pricing model is, I won't go into discussion about indexation, Sam, but I guess it's, we do try to reflect the fact that, we have cost data which is 3 years earlier than the year that we're actually pricing, and so that, costs and some of that's wrapped up in new health technology, changes. So the indexation methodology sets that at what would be the current prices. In terms of how can states and territories provide a funding source, that's really going to have to be a question, I think, for the states and territories.
Okay, well, this is the final question I have in front of me. It's a little off topic, but I'll ask it anyway. So the Aged Care Royal Commission proposed that Ipper be involved in the pricing framework for residential care. Also, the Commission proposed that local hospital networks provide specialist medical and allied health services to residential and high-level community care clients in their areas. Has Ipper started planning for working out the pricing for these initiatives?
We have started some work on aged care. It's no secret that there were budget announcements in relation to Ipper's remit being expanded to accommodate pricing of aged care, initially residential aged care, but also into the future potentially community or care in the home for aged care. Have we sort of, develop draft pricing policy or methodology? No, that's still quite a long process. We're at the stage where we've got to do some establishment set up with our own agency, and discussions have started with stakeholders and with the department about what our role is and how we might undertake that work. But it should be a very interesting piece of work, but we don't really have any detail or insight at the moment. It's too early for that. The budget only happened in May.
Okay, well, I've got a really quick follow-up from the audience member regarding the breast milk, and then we'll sort of have to wrap it up. But so the question really is, in what time frame is these do the costs, I guess, get realised within the price, and will it be 3 years before the price is adjusted? And because they're saying they're paying for it now, but without the actual funding.
Typically, yeah, it would be about 3 years when those. After those costs have been reported. There are cases where if there's an extremely large cohort of patients and it's an extremely expensive service where we can, identify costs and activity using proxy measures to introduce adjustments earlier in the piece. But that's, I guess, the exception and needs a very strong or significant covered evidence base behind it.
Yeah, so I think that's all about all we have time for today, but I might just wrap up with one final question of each of our panelists. I wonder if each of you could provide your one key takeaway for producing a successful submission.
I'll start off and say I think it's important that you provide a detailed submission, but not necessarily having to respond to every question that we have within the consultation paper. So using your expertise to provide thorough responses.
You go, Sam.
Data include data in the strong evidence base so that we can account for that.
I was going to say, be cognizant of what Ipper's remit is and what can actually be managed under a pricing methodology change. Obviously, pricing is an important lever, but getting widespread system change, there's only so much a pricing methodology can do. So just be cognizant of what our remit is and whether a pricing solution is really the solution that we're looking for.
I gave an incredibly terse response to my question because I noticed we had about 5 seconds left, but we're going a little bit over, so I should probably clarify around, and I mean, I've touched on this plenty already, but where there are submissions suggesting changes in methodologies or how costs will be accounted for particular programs, the breast milk questions being a prime example. So what's really be able to evaluate that or respond to it appropriately is either is basically how we can account for that in our data, how we can identify those patients, how we can identify those costs when they're submitted, and where there is, you know, and it's crucial for something like that as well around being cognizant that it is like a national model, so where there are adjustments or suggestions that, you know, might affect a very small cohort of patients in one facility, in one jurisdiction. It's not always necessarily something we can appropriately introduce into a national price. So just keeping that in mind.
Okay, thanks guys. Well, that's a wrap, I think. If anyone has got any further questions about the consultation on the pricing framework or require assistance with the submission process, please contact Ipper via email at inquiries.ihpa@ihpa.gov.au or by phone on +61 2 8215 1100. You can find all this contact information on our website, ipper.gov.au. So thank you to our panelists and our audience for taking part in today's discussion. See you all later.